Hey, I'm really excited to lead the panel of physicians in this very sophisticated meeting. And I would like to thank very much Yaakov for allowing me to do that. There's Yaakov. And Daphna and Nahum for helping and doing that, the sessions with me. I will start by giving a short introduction about mostly new things and some of the old things in ophthalmology. Can I have my slides? Basically, we all know that ophthalmology has changed a lot in the recent decade and is continuing to change. And I chose a few small highlights in my life as a retina specialist that I could term exciting innovations in the field of ophthalmology. So everyone knows that there was a very exciting, there are many exciting breakthroughs in the management of eye disease with new drugs that developed the new techniques and really reducing. לא לגעת במה. It was better when I touched. Okay. I think now it's okay. So the innovations that we have already and are changing our lives every day are new novel anti-VEGF formulations and drugs and dosages and mechanisms of action, new treatments, new technologies, cell and gene therapies, and also trying to optimize the available therapies. This include both technological innovations, home monitoring, and even home treatment, and a lot of use of AI. So just for the ones here that are not physicians, macular degeneration has two arms. One is the wet disease that you can see in the upper part of the slide. And we know that due to changes and developments in this field in the recent decade, incidence from blindness from macular degeneration was reduced by about 50% in most countries. However, it's not optimal yet. So as compared to the clinical trials that you see in the left side of the slide, in real life, the results until today, even today, are not that good. One of the new things is bispecific molecules that are using not only the anti-VEGF pathways, and we have the results, for example, of faricimab that show non-inferiority to regular monthly or bi-monthly treatment that was before, but now about 80% of the patients can get the injection every 3 months and 60% every 4 months. And we have other formulation, high-dose aflibercept and others. We're also coming back to devices, the port delivery system, that is an intraocular drug delivery system that is implanted in the eye in a surgical procedure. And it has been shown that when it's implanted, basically most patients do not need a refill for 2 years, which is amazing. The development was stopped because of some technical difficulties, but now it's coming back, and I think it holds a lot of potential. But the most exciting developments are in the field of dry, non-neovascular macular degeneration. And over the years, again, the last decade, there have been multiple developments, most of them in the cascade of complement inhibition. Maybe it's not intuitive, but complement inhibition, there is a logic to that it can solve non-neovascular macular degeneration. Unfortunately, here too, the only thing that this drug that is a first of a kind, pegcetacoplan in this instance, there is another drug, Zimura, but what it can do is it can slow the progression. It's not stopping the progression, it's not improving the situation, it just slows the progression. However, also slowing the progression can be important if you look at an eye treated as compared to the fellow eye. You can see that the fact that over the years the lesion grew less might have an impact on the scotoma, on the center part where the patient doesn't see. You heard Arya talking about Precise Bio, and this is an example of a technology that can actually restore vision by implanting these pigment epithelium printed cells that can really maybe help also improve vision and not only try and slow the deterioration. Another very important field is the field of home monitoring, because when we see the patients only during visits, there is a limited amount of information that we have. There is a gap, and this gap can be filled by home monitoring that is analyzed by AI. The technology concept is that the device is prescribed by a retina specialist. A monitoring center sends the device to the patient. The patient's task is to perform daily examinations, and then they're automatically mounted on a cloud, analyzed by AI, and if a preset threshold has been met, an alert is sent to the clinic. Of course, this cannot be done without analysis by AI. Here you can see on the left side of the screen, the OCT outputs, the B scans, the segmentation, the localization of the fluid, the production of map and of trajectories, and it can provide a personalized way to manage your patient. We have some innovations, also Israeli innovations in the field of the surgical field, from the surgical microscope that is the same for the last dozens of years, to 3D monitoring display, and the technology that was developed by Elbit, by Bionics, a spin-off of Elbit, which is based on Elbit's pilot head mount and display. By using the head gestures, the pilot that sees everything on his head-mounted display. This is a virtual screen that you can see here. He can actually control everything and also guide munitions. Here you can see Professor Barak and myself using the technology adapted to ocular surgeries. The screen that you see is a virtual screen, and it helps us not only get rid of the microscope, but to incorporate a lot of preoperative, intraoperative data, and also a lot of applications, software applications. The sky is the limit, like a cellular phone, tool indication, tissue indication, are you going to touch the retina, and so forth. So that was just a little drop of my world on innovations that we are dealing with every day. And thank you very much. I hope it will be a good platform for the discussion. So you can close the slides, and I would like to ask my panelists to come up to the podium. Professor Itai Chowers, right? Chowers, Itai Chovers, the chair of the Division of Ophthalmology at Hadassah Medical Center. Professor Yaniv Bar-Kana, where are you? Please come up. Whom you know already who he is, and you heard him already talk. Yaniv will represent the anterior part of the eye in this panel. Professor Guy Kleinman could not come last minute, and I would like also to invite Dr. Omer Trevitsky from the Tel Aviv Medical Center, who is a serial innovator in the field of ophthalmology, and to help in the panel. If there are any questions, comments, someone wants to ask the panel something, please feel free to raise your hand, and you will...
First question, חייבים את הפרוג'קטור הזה?
Okay, so we don't have a lot of time. I will ask most of you all the questions, and please keep your answers quite brief, and so that we can let the audience have a chance to have all your thoughts. So first of all, to each one of you, what is the most exciting innovation in the field of retina, glaucoma, retina, or other fields in ophthalmology in the last, let's say, 5 years for you? Itai.
So I would like to mention two. The first is in the field of gene therapy, which amazingly was incorporated into the clinic, at least in treating inherited retinal degeneration. This is a real revolution that is ongoing.
And also FDA approved.
And FDA approved, and even in the health basket, in the Sal HaBriut in Israel, we have performed almost all of the patients that underwent this surgery. We have performed it in Hadassah, and this is really a revolution. And there are many studies ongoing trying to apply gene therapy to IRDs, but also to neovascular AMD and also to dry AMD that you mentioned. So this is one. The second thing that I would like to point out is the revolution that is ongoing in terms of incorporating artificial intelligence into ophthalmology. But this is a really amazing, and it's happening today. There are so many different applications for AI in ophthalmology, from screening in the community to identifying disease in the clinic, monitoring treatment, predicting progression, and on and on. And this is really one of our most exciting front today.
Thank you.
Yaakov Michlin presented me to someone. He said that he brought me here for Ifcha Mistabra. So first, let me share with you what hasn't changed in glaucoma.
No, that was not the question. You'll get this question.
Okay,
That
בסדר.
will be the next question.
So obviously what has changed, very little, but what has changed in glaucoma in recent years is the new surgeries. So we did trabeculectomy for 80 years, and it's not surgery fit for today's lifestyle, not of the doctor, not of the patient. And the recent surge and continuing surge of newer surgery, which is much easier on the eye and the patient and the physician, that's the recent...
And with the use of new technologies, of course.
Yes, of course.
So, Professor Lazar was my mentor and the head of the department for 30 years before I became the head of the department for 30 years. He always said that trabeculectomy, everyone said it's 99% success. But then more and more surgeries appeared. So he said, if it's so successful, why do we need more surgeries? So you're right.
So, but just to make the point that sometimes the largest innovation is here and not in the technology.
Amen.
We do gut surgery, and for that you need a gonio lens and a knife and a piece of suture.
Amen.
And that was available 50 years ago.
Okay, so I would say like I think the most important, the way I see it, is the idea that we got a proven drug for dry AMD, which was not available for our patient for the last decade, as you just said. It's not what we expected to be, but it's going there, and I think we learned a lot from the last 2 approved drugs that we got over there.
Okay, I'll get to what you wanted to say in a minute, but first I wanted to ask each of you, and let's start with Omer now, what is the larger barrier, the biggest barrier in adopting new technologies and new innovations, both for the clinician and in the development? 2 short sentences from each of you.
So I think sometimes, as we see today, especially in the complement, I would just move forward, is like physician education. How can you actually follow, identify patients that actually gain from the new treatment? That's like one of the barriers. And second is compliance of the patients to get the new treatments, and some treatments require quite requires monthly injections, so that's definitely a barrier.
Any short answers? What are the largest barriers?
In the US, it's reimbursement. Outside of the US, it's reimbursement and conservatism of doctors. I'm talking about surgery, of course. But we want the best for our patient. Some of us wait for a long time before we embrace new technology.
Okay.
I think, well, first I agree if physicians are conservative, and that's good because we would like to protect our patients. The second is that physicians do not have time. Everything that is time consuming is a big issue for us to incorporate into the clinic.
So you've already answered the first part, the 3 of you, so let's go to the second part of my question. What is the barrier in bringing a product to be commercial? Because all of us, all of you, Itai, you are an amazing entrepreneur, and Yaniv and Omer, what is the barrier that it's so difficult to bring a product to commercialization?
Well,
This side, okay. So there are multiple barriers. For us as physicians, again, we have to understand what's the processes. We don't know that. We don't learn that. We have lack of education, certainly lack of sufficient knowledge of the process, not enough networking, ecosystem that is not sufficiently supportive, and so on. This is a major barrier for a physician. There are multiple other barriers in the process: funding, regulatory issues, business model.
I think that actually in Hadassah Medical School, Dina Ben Yehuda did a big thing of teaching students.
We have
the process, right?
so there's a track of רפואה חישובית that Professor Dina Ben Yehuda has established in the medical school, which is very helpful. And we see these students coming into our department already, and this will be a completely new, major change, new generation. And also in the hospital, we have our small hub of innovation in the seat and in the research fund.
Short answer, because I have 2 more questions for each of you.
I'm involved in 3 endeavors, 2 devices, 1 pharma. Raising money is extremely difficult. I don't know how it was 10 years ago, but it's very, very difficult. I think the 3 of them are fantastic. In the pharma industry, I am learning that the patent thing is a large barrier, because until you finish phase 3, you don't have enough years for the patent. A refrigerator you can invent in 1 year. A drug, it takes 15 years just to bring to market, or 20 years.
I think a lot of regulation, like we're dealing with a lot of regulation, bringing the product to commercialization, as you said. I think it's important, because as Itai said, we kept our patient safe because of that, but it makes a really long process to bring it over.
Okay, so 2 more questions. The last will be the one that you wanted. What do you think will be critically different 5 years from now in your work as a retina specialist?
Well, definitely what Itai just said, AI. I think we see...
You will not just examine patients anymore?
I believe that in the near future, a lot of the patients won't need to show up in the hospital. They, as you said, home OCT, or it will be home-based or CVS-based, whatever. Patients will just arrive to the...
So not examining patients?
I believe we won't examine all the patients, yes.
Okay, 5 years from now in glaucoma, your segment.
I'm a great believer in AI. I think it's not only cute. I think that we are humans, and many of us are not the best doctors. Some of us are the worst doctors in Israel, and they see patients. That's Seinfeld said. So AI, I think that's a big drive for the AI in medicine. And even telemedicine, today, other than gonioscopy, my technician does everything in the clinic. I don't need to bring them. So I think, yes, this will strengthen in 5 years. And all of us, or cheap physicians in India will be doing a remote medicine, maybe remote surgery. And yeah, this together with AI, I think is going to change us very quickly.
I think everything that...
5 years.
First, I agree with what Yaniv and Omer said, but I think everything that we're going to do will be surrounded by a digitalized, AI-based envelope, starting from the clinic, the way we see our patients, then educating the patients, how to use the treatments that we want them to use, then at home monitoring the patients. So we're going to be surrounded, or the patients are going to be surrounded by these envelopes, and we'll have the challenge to connect it into one system that give a continuation of treatment to our patients. And one last note is, I think we will be able to treat disease that we are not able to treat today, particularly inherited retinal degeneration. I think we are on the verge of a revolution there.
So that's very optimistic. Okay, to the last question. We start with Itai. What do you think that does not need to change, or that you're sorry that has changed from the past 5 years? So something that we used 5 years ago, we don't use anymore, and you're sorry about that.
So I actually wrote a paper a few years ago about de-skilling in ophthalmology. There is a gradual process in medicine where we lose our skills with time. Some of the skills that we are unfortunately, I think, using is communicating with our patients, and this is a major thing that we have to preserve and protect, and against the pressure that's coming from mostly business-oriented views of the system.
Yeah, I want to just comment on that going into AI actually does not mean that we will lose the contact with the patients. On the contrary, we might have more time to not to put our face in the computer and write, but rather more relate to the patient, where everything will be written by our technician in India or something like that.
That's the optimistic point of view. It's possible, yeah.
Yeah, please.
Is this the last question you promised?
The last.
So,
1 minute.
so we're talking about 5 years and everything will be AI. Today, the printout that we get from the visual field machine is exactly the same that it was 6 years ago. The printout that we get, you know, when we
Are
were...
you sorry about that?
Yes, I think it's ridiculous. When we were interns, we did EKG. We would receive some, diagnosis at the bottom. This was decades ago. When you get an OCT of the retina or for glaucoma, you get dozens of numbers. You get all these graphs, and I make money from it because a fellow physician sent it to me because I'm a glaucoma specialist. But how come we don't get even a word of analysis?
Is there something that you exercised 5 years ago that you're sorry that is not here today?
So things haven't changed too much. We use the Goldman tonometer, we use the Humphrey machine.
5 years ago you were in high school, but let's try.
So I was about to say, like 5 years ago, I was like really young resident in my early residency. So I don't think, me, I'm like always pushing forward. And I would say that, if something is not meant to be or not meant to move forward, so we probably wouldn't use it, that we keep in the past. And we know we still have a few stuff we're still using from, old age. So I can't find anything, I would like to keep.
Yeah, just to conclude, when I was a fellow at Johns Hopkins, we were reading fluoresceins on a light box on film. And when it became digital, it started at that time, I went to my boss, Neil Bressler, I said, how can you even think that it's the same? When I look at the light box, I see stereoscopically, I see all the details. He said, you're right, but in 10 years, you won't have any film anymore. So you need to get used to it. So with that happy note, I have to conclude the panel. My time is up, right, Daphna? And thank you very much to my panelists and to the audience.